Hi everybody. Our lecture today is about pain relief in labor. The objective of this lecture: students nice to know non-pharmacological methods. They should know the nervous supply and location of pain. It is nice to know factors affecting pain, and you have to know information about opioid types, modes of action and route of administration. Must know information about inhalational analgesia, epidural and spinal analgesia and anesthesia technique and the duration of action, and the indication and complication of these two methods of analgesia. Pain relief in labor. The method chosen for pain management in patient who presents with labor depends on the obstetrical history. For example, she is multipara. She had previous two normal deliveries. Differs from a woman with, for example, prime gravida lady. It depends on the course of the labor. For example, early labor, choose the type of analgesia differs from the patient with advanced labor. The estimated length of labor is also a factor should be taken in consideration while you try to choose the method for analgesia. We have non-pharmacological methods. For example, relaxation and breathing exercise. The woman usually be encouraged by her family to take deep, or the nursing staff to take deep breath and relaxation. This will help to manage her pain. Some countries uses relaxation in warm water, and process of labor can be complete in special swimming pools with warm water. Trans-electrical nervous stimulation, and this picture shows the method of putting these electrodes in special area, and this will help to manage the pain. The origin of pain in labor. The site of origin from the uterus and cervix, for example, the contraction and distension of the uterus and dilatation of the cervix. The pathway through the efferent nerves through T10 to L1 and posterior rami of T10 to L1. The side upper abdomen to the groin, mid-back, and inner upper thighs. It is a referred pain to that area. Periuterine tissue, mainly posterior tissue. Pressure often associated with occipito-posterior position and pressing on the flat sacrum. This pathway through the lumbosacral plexus L5 to S1. The pain area is mid and lower back and back of the thigh referred pain. Lower birth canal, distension of the vagina in advancing stages or the last or second stage of labor. Distension of the vagina and perineum in the second stage. This is carried through the somatic nerves S2, 3, 4, and the pain in the vulva, vagina, and perineum. The bladder over distension. Once there is complete engagement and descent of the presenting part, this will press on the urethra and causes distension of the bladder. Sympathetic pathway through T11 to L2 and parasympathetics through S2, 3, 4. Usually the pain area in the suprapubic area. Pain from myometrium and uterine visceral peritoneum. This is in cases of abruption or scar dehiscence, and this is carried by T10 to L1, and it is referred pain at the site of pathology. Nociceptive pathway involved T10 to L1 during labor. The afferent nerves carried the pain sensation through it into the T10 L1 and also through S2, 3, 4. in cases of complete dilatation and descent of presenting part and delivery through the birth canal. Sorry. The ideal analgesia in labor should have good effect, that's to say efficient to decrease pain, easy to be administered so it can be taken by the paramedical staff or it doesn't need specialist, safe to the mother and the baby. I should take in consideration that I'm dealing with a pregnant lady and her fetus in utero, easily reversible, doesn't take that much long time, and does not interfere with uterine contraction. I don't want to use any medication that will decrease uterine contraction and hence it will delay the process of labor. Also, the pain management methods should not affect the mobility of the patient as much as we can. Factors affecting pain perception in labor. There is difference between each woman from another one regarding the perception of pain. It depends on factors affecting that pain perception. For example, mental preparation. If I prepared myself for the labor process, I will accept the pain for a certain degree. If she had good family support, if her relatives and family beside her, if they encouraged her, if she's away, for example, in another country and she's alone, she will feel pain more. Medical support. If each woman has good medical and paramedical support, the pain will be decreased for sure because they will manage it easily. Cultural expectation. If there is a concept that labor process is something normal and much of the females will enter into this process and all of them have delivered good babies, so you are not different from them, this is part of the reassuring. Underlying mental status, if she had some mental problem, for sure she will not accept the pain sensation. If she had intact mentality, this will help to manage pain. Parity, difference between multipara and primigravida lady. The size of and the presentation of the fetus, as we mentioned, if it is occipito-posterior, the process of labor will take longer time and the pain will be more because there is a pressure on the sacrum posteriorly from the occiput. Also, if the baby is of average size and small size, it will be delivered much easily than the baby which is bigger size. Maternal pelvic anatomy, if it is adequate, the process of labor will pass easily and the pain will be much less. The duration of labor, if she presents to us with advanced labor in active stage, for example, differs from early latent phase. Medication and its availability, if I had much medication and good facility to deal with different types of pain and I have different methods of analgesia, for sure I can manage each pain on itself. The pharmacological methods. We have opioids. This can be used widely, but it causes sedation of the mother and can be explained as a decrease of pain. Also, it causes delayed gastric emptying, nausea and vomiting, so we have sometimes to give antiemetics. It can be given by the paramedical staff or by the nursing staff, midwives. It's easy to be administered, doesn't need specialist. Pethidine also can cause respiratory depression of the neonate, so I should provide naloxone beside me or in the neonatal care unit in order to use it if there is severe depression of the neonate. Diamorphine is a better analgesic than pethidine, but it is with more respiratory depression, so we prefer to use pethidine. The opioids are given by IM injection, but more effective way is by subcutaneous or intravenous infusion. Another one is fentanyl. It is short half-life, it has short half-life, makes fentanyl suitable for prolonged use in labor. So it is easily metabolized, so I can use it in intermittent methods, either as intravenous bolus or as analgesic administered by means of patient control analgesia delivery system. I can put it in a fluid, and the patient can't control the administration of this medication because she's aware about the side effect, the type of this medication. This is applied abroad, not in our country really. It provides a reasonable level of analgesia with minimal neonatal depression. The usual dose of fentanyl for labor analgesia is about 25 to 50 microgram intravenously. The peak effect occurs within 3 to 5 minutes and has a duration of 30 to 60 minutes.